Dr. Tolib Mirzoev, who I will introduce to you now. And after I do the introduction, I will give a few ground rules for today's session, and then we will start. So Tolib is a global health researcher and an associate professor at the University of Leeds. His expertise covers health policy analysis, health systems strengthening, and capacity building in the Global South. Tolib is the head of the Nuffield Center for International Health and Development and is an elected member of the Board of Health Systems Global. So that's Tolib, and I'm sure you will learn much more about his work when he presents today's seminar.
Thank you very much. And good morning, good day, good evening, and good night, everybody, depending on where you are in the world. It's great to see such an increased interest. And I wanted to start with huge thanks, particularly to Dr. Anna Manzana for inviting me to speak at this really up-and-coming webinar series. It's an absolute honor and pleasure. And we have got a brilliant moderator as well. So just wanted to kind of shout out to Seyé, Dr. Abimbolá as well. So today's topic is about kind of methodological lessons that we have learned from one of our case studies on tracing the different theories in large-scale health programs in low and middle-income countries. So what I would like to do is, as you would expect, kind of do a bit of scene setting. So in the introductory part, I will introduce the program that we had evaluated and the study that we had conducted. Then in the second part, I will take you through the key phases that we went through in our thinking processes and then sort of share some of our emerging reflections. And then I'll end up with some of the hopefully useful lessons learned from this fascinating experience. So to start with, between 2012 and 2015, the government of Nigeria had implemented the Fuel Subsidy Reinvestment and Empowerment Program, in which they have reduced fuel subsidies within the country and rerouted this amount of money to social protection scheme. And that had one of the components of this scheme was focusing specifically on improving maternal and child health, particularly in rural and remote areas. That program was called SURE-P, so that was the acronym, and the /MCH refers to this specific component. So that program had two broad kind of elements, what the program architects called supply element. So it's basically the health systems aspects that involved recruitment of different cadre of staff, improvements to the infrastructure and provision of equipment, supplies and medicines, as well as the demand side that was involving mobilization of ward development committees. So these are the kind of community structures to improve uptake, but also awareness of the health services in local kind of communities, but also improve the participation of local communities in decision making, not health specific, but more generally, as well as provision of conditional cash transfers to women for the uptake of services, particularly antenatal care, deliver in health facilities, and then postnatal care, particularly immunizations and vaccinations afterwards. This study that we conducted is called REVAMP, and if you Google REVAMP, you will probably come up with things like Swedish Rock Group, or there are quite a few kind of property improvement programs also called REVAMP. So I wanted to kind of differentiate between our study, which is about determinants of effectiveness and sustainability of novel community health workers program in improving maternal and child health in Nigeria. So it was originally 5-year MRC ESRC and UK8 and Wellcome Trust funded study. But recently we have got an extension to be able to present at the next Realist conference in Dublin in February 2021. So hence the dates are showing that. And I wanted to particularly acknowledge the inputs from the Health Systems Research Initiative, who financially supported this study. But obviously, everything that we say and we publish does not necessarily reflect the views of the funders. So this study has been implemented by the partnership between what we call the Cominec. So it has nothing to do with Communist Party. It's the College of Medicine at the University of Nigeria in Ugu campus. And the team included BSc Ozuchukwu, Obi Onujakwe, Nkole Ezuma, Eni Etiaba, Chinyere Okeke, and a few other members of the team. So brilliant group housed in the Health Policy and Research Group in the University of Nigeria, as well as what we call the Leeds team. So myself, Dr. Anna Manzana, has provided brilliant mentorship and guidance on methodological aspects of realist evaluation. Then Team Answer, Basi Ibensa, Joe Hicks, and various other colleagues as well. So it's quite a large kind of collaboration and very strong partnership, hopefully equitable partnership. That's what we would like to believe. So ReVAMP aimed at assessing the effectiveness and sustainability of the SURE-P MCH. That was particularly focusing on Anambra State, for those of you who are trying to sort of get a sense what Anambra is on a map of Nigeria. So it's highlighted in red. So it's kind of southeast corner. And the approach we took was to kind of select three clusters. Two clusters with two variations of the SURE-P program. One with only the supply component, so SURE-P MCH. The second cluster with all the kind of health systems measures, as well as the provision of the conditional cash transfers. And we have also chosen the control site with no implementation to be able to kind of compare the results. And of course, it was the realist evaluation. So realist methodology provided the overarching kind of framework for it, but it is a cross-disciplinary and mixed method study. So in terms of kind of the starting point, I think our study was underpinned by what we call the program theory, or theory of change, which is in the top of the slide. And basically the conceptual framework involved the classical Dovidian thinking of inputs leading to processes, leading to outputs and outcomes, perhaps reflecting some of the kind of established health policy and systems research theoretical understanding there. And we particularly emphasize the context as permeating through macro, meso, and micro levels, and sort of involving the combination of politics and finance and health systems organizations and culture. And the study was underpinned by 5 objectives shown at the bottom of this slide. So I've kind of summarized the key focal areas of the objectives. And the main thing was basically just to understand how the combination of different inputs, such as staff and supplies and infrastructure and finance, catalyze the different program mechanisms, perhaps intervention mechanisms, and I'll come back to this the nature of the mechanisms and which immediate results and more distant results are generated from the study. In terms of the methodological sort of approach, the study design involved 3 kind of classical phases of the realist process. So first is the theory development, gleaning and development, I should say, theory testing and validation, and the third phase was very much kind of theory refining and consolidation and lessons learned. And in terms of the methods, we used the combination of in-depth interviews, facility exit surveys, focus group discussions, analysis of the data from the health management information evaluation system and SureP costing data, as well as the document reviews. So this kind of conceptualization shows the purpose of the different methods at different stages of the study, as well as how they kind of feed into each other. So it was a fairly complex undertaking that led towards kind of identifying the specific program theories and tracing those program theories throughout. So more details, of course, we haven't got too much time to dive into the kind of context of the study methodology, but if you're interested, everything is documented in that we have written in Implementation Science a few years ago. So please have a look, and very happy to engage, of course, with any follow-up questions. But the main purpose of this talk is to share some of the lessons from what we called our methods paper. So it's our experience of tracing two specific theories throughout the ReVAMP study, the trust theory and the security theory. And I'm using the shorthand, and I will explain this a little bit later. But at this point, I think I've just noticed that the screenshot didn't really say that, but I wanted to emphasize that both Anna Manzana and myself are the joint first authors, and it is a collaborative paper between the Leeds team as well as the Cominac team. The three phases were very much iterative, kind of mutually reinforcing, rather than sort of sequential. And they had very different kind of foci issues and lengths. So the first phase was very much kind of few months time phase, and I will dive into specific issues later. Involved largely theory gleaning and development. Then the second phase took just over 2 years, sort of rigorous development and refining of theories based on empirical data, the literature, the series of meetings within the team. And the third phase was kind of aimed at pulling it all together, testing, consolidation, validation, and refinement, all of that. So as you can see, the kind of the terminology goes a little bit back and forth, so that we didn't really have very fixed labels for the phases. So the trust and security theories, they kind of run through all three phases of the project. And this visualization gives you an idea of how our thinking about the program theories has evolved. So the different shading gives, well, the dark shade, the kind of almost the dark gray, gives you an idea of how the security theory evolved, and the lighter gray shows how the trust theory evolved. But basically, in the first phase, we started with overall theory of change that then was subdivided into supply and demand side. That was very much driven by the program architecture, so the logic of the SureP program. And then each of those supply and demand side then were kind of subdivided into specific theories, so supply 1, supply 2, and so on, and D1, D2 refers to demand 1, demand 2. And then we then, during the second phase, iteratively kind of developed and gleaned and developed those theories. And then during the third phase, we have reconfigured them, and sort of the theories in shorthand, of course, on the right side of the slide, then inform a series of papers that we have actually written from the project already. So what I'm going to do now, I'm going to dive into each of these phases just to give you a flavor of what was the thinking and how we kind of progressed with this. So the first phase, as I said, was aimed at gleaning the theories from mainly program documentation, but also largely from program architects. So the lead for the program, the SureP program, had a really important kind of role in explaining some of the inner thinking and some of the inner kind of connections that were not always evident in the program documentation. As part of it, what we did, we actually developed a fairly complex logic model to understand really the kind of the thinking and the connections within the SureP program. And we have documented that in a paper that you can see on the slide too. We have also assessed the quality of data from National Health Management Information System in Nigeria, just to get a good sense whether we can kind of use that data reliably or whether we need to collect or indeed abandon some of the questions there. And we, of course, engage with literature as well. And then that phase also involved quite a large component of capacity strengthening during what we called the Leeds meeting. So that was in, I think, September 2015, where Anna has kind of kick-started the overall kind of realist philosophy in both Leeds as well as Cominac teams. But then it was followed up by a series of step-down capacity development workshops in Enugu, as well as series of web calls and webinars and teleconferences. A photo here is Basi and Anna connected through GoToMeeting. Basi is also connected through the WhatsApp. And there was also a speakerphone, so you can get a sense that we explored so many platforms there. So the key reflections from the phase one, and this is the snapshot from the previous kind of diagram, is that the theory gleaning was largely driven by the program design. So the two kind of program theories were very much mirroring the program architecture, whether it was good or not. I think we were reflecting further down the line. But the issue was that neither security nor trust as themes, as concepts, were really explicit in the program documentation. So they were very much implicit in references to the working environment, infrastructure, and staff performance, and we had to kind of almost tease them out, and then they kind of crystallized a little bit further down the line much better. Security was a little bit clearer during this initial data collection that we have conducted. For example, people were referring to very clearly to perimeter facing and night guards and so on, whereas trust emerged a little bit indirectly still in references to staff motivation and user satisfaction, service user satisfaction. And on reflection, I think we engaged largely with empirical literature, which was driven by program logic rather than theoretical, substantive social science theories. During the second phase, I think we had much larger data collection and deeper engagement with empirical and theoretical literature. The data analysis at this point was very much kind of iteratively conducted, but also over the period of about 4 to 5 weeks. So we have split ourselves into about 5 groups, and then came together at a 2-day workshop in Enugu in February 2017. And from there, we have identified kind of 15 themes, and then we repackaged those themes into the 8 program theories that I've shown earlier. And that was an interesting exercise on its own. So the 15 themes are shown on this slide here. So as you can see, security was very clearly demarcated, an explicit theme, although it referred to security of health workers, staff feeling safer to provide MCH care rather than kind of security or safety of health service users to consume healthcare. Whereas trust was kind of still kind of evident as part of the different themes, ranging from availability of drugs and sort of equipment and supplies, and all the way through to relationships building and sort of supervision of staff and so on. This is just to give you an example of these specific 8 theories that were developed at this stage of the project. So the third supply theory, S3, was very much kind of pulling it together still in a way that kind of we had clearly demarcated some context, some mechanisms, and some outcomes, but in kind of tentative causality propositions already. And the The second example is one of the program theories on trust that was kind of picking up particularly on the sustainability of trust within the health system after the withdrawal of the SURE-P. And as you can see, there is still kind of causality proposition statements there, but also there was kind of still clear demarcation between the contexts, mechanisms, and outcomes. And that demarcation was helpful on one hand to kind of go through the CMO configurations and so on, but it was also, we tried not to restrict ourselves too much to that. And at this stage, I think we iteratively collected further data as the theories progressed. So we were kind of developing theories and then looking for the data and then sort of refining the theories and so on. So that iterative process was really kind of important for us. So on reflection, so we truly felt that at this stage we had more retroductive reasoning rather than inductive reasoning, sort of inductive building of the theories, or maybe kind of deductive approaches to the analysis with tentative causality propositions that were included and then tested in particularly interviews, but also focus group discussions and other data sets. And we had used the magnifying glass metaphor here to engage with largely empirical data on what other health system studies found, but also increasingly theoretical literature too. So during the phase 3, I think we had a much smaller scale of the data collection, but much more intimate kind of engagements within as well as between the teams. And we had regular meetings, regular teleconferences, and we brought in the series of substantive social science theories into the what Anna has introduced as a concept, social lab. And that was an interesting kind of exercise on its own to kind of advance our conceptualizations. Deeper engagement, I think, was really helpful at the last stages of the project, just to consolidate, reshape, revamp some of the theories. Just to give you an example, I think we used what we call the knowledge summaries to summarize the key issues emerging from the data, both qualitative and quantitative, structured still by contexts, mechanisms, and outcomes, but clearly linked, and also demarcating between the different levels of the contexts and different parts of the mechanisms, the well-known reasoning as well as the intervention parts of the mechanisms. And the narrative you can see in the bottom has progressed to a much deeper engagement with, in this particular case, it's the security, but also the trust as well. This is just to give you an example of some of the kind of a flavor, even though this is a methodological kind of piece, flavor, some of the empirical substance there. So both the communities as well as the policymakers were really emphasizing the importance of safety and security. And a petty trader, for example, the neighbor, the pregnant woman who accompanied her, they went to the health facilities, they stood for almost an hour, there was no response because there was nobody kind of to open the door. And they had to kind of throw stones at the roof to get attention. And the same was kind of echoed by the policymaker, who reflected that for 40 primary healthcare facilities, there was only just one security guard. Ironically, most deliveries were usually happening during the night, so there were lots of kind of barriers there. And incidentally, Annie Etiaba has led the paper that had actually came out 2 or 3 days ago. So I have just put this snapshot of the reference there at the bottom of the slide. So do have a look, see how you feel, and I'm sure Annie and all the other co-authors would welcome your kind of thoughts and engagements. But that paper is more kind of empirical paper on security theory. So the same approach was used for the trust program theory. So knowledge summary guided our engagements with the literature, with the data, iterative sort of engagements with empirical as well as the theoretical concepts. And the narrative has progressed into much deeper conceptualization of particularly mechanisms, but also kind of the much clearer causality propositions within the theory development. And these are some of the quotes from this trust program kind of data set, so to speak. The two quotes from the service users in the top left corner basically emphasize how happy they were during the SureP because the program has brought all the kind of the incentives, largely material incentives to enhance their willingness to come healthcare. The quote in the right top corner sort of mentions the health workers' perspective that when the SureP has ceased to exist, then there was quite a detrimental effect on people's kind of on availability of supplies. And what we also found that actually, despite the withdrawal of the SureP, there was that element of what we call residual trust. So the incentives that the program has brought in actually catalyzed communities to continue using maternal and child health care and actually engage and encourage others to use healthcare too. So at a theoretical level, sort of security was underpinned very much by the complementary body of interdisciplinary literature on fear of crime, and gender, structural factors of security, and political and socioeconomic issues, and so on. Whereas the literature on trust was largely kind of progressively selected to capture the different levels, the micro, meso, macro determinants of trust, the taxonomy of factors of trust. There was a brilliant special issue in social science and medicine in the mid-noughties, I think, led by Lucy Gilson and colleagues on trust. And later on, we kind of drew particularly on social capital theory for the residual trust. So that was an interesting kind of reflection. So we faced three conceptual challenges at this stage. First was kind of toggling between the level structure, sort of comparing the CMOs, which are very kind of specific with empirical health systems literature versus engaging with substantive theories at the middle range theory and into broader transferability level. The usual challenge of what causes what, what's the chicken and what's the egg. And I think it was a useful exercise to clarify this to ourselves before being able to articulate this to other people, particularly kind of in the papers, but also our participants. And also, there's no established protocol for what substantive theories to use in realist studies. So our iterative dipping in and out of the literature, both theoretical and empirical, was really helpful to kind of sift through fairly large amount of theoretical angles and on both security and trust. So on reflection, and incidentally, this is our brilliant Annie Etiaba presenting the security theory as a poster at, I think it was one of the conferences organized by either AFIA, African Health Economics Association, or ASFA, African Association of Schools of Public Health. But on reflection, neither security nor trust were really explicit in the program design. Security, actually, as you have seen, emerged earlier. Maybe perhaps it was more tangible, more visible. Trust was a bit softer. It was cross-cutting, and that was an interesting kind of observation on its own. The data set for security was exclusively qualitative, whereas for trust, we also used quantitative data from the surveys, from the facility data to see kind of the patterns of utilization of healthcare in particular. And the cross-disciplinary discipline, expertise from social sciences, health economics, statistics, broader field of health policy and systems research has really kind of been to the benefit of the project. So we really kind of pulled together our heads, and it was very, very constructive and productive. So what have we learned? First and foremost, of course, every theory is unique and complex. But we're also learned at a higher level that actually realist evaluations are important, though time-consuming approaches to generating really practical applied implications for health policies and practice. And that overall message was really helpful for us, for our stakeholders, but also for our kind of respective teams. And that overall lesson is underpinned by three specific recommendations and perhaps observations. First, we felt it was important to pitch theories at the right level of abstraction for rigor and policy relevance. Maintaining that balance was really critical in our sort of engagements with that, because too higher, it would be kind of too abstract, and too lower, then it may not be generalizable. Second, as you know, realist studies require different nuggets of evidence and can be challenged. And sourcing those can be a very sort of huge challenge, particularly in resource-constrained settings where there is no established culture of sort of extensive program documentation, for example, and so on. And last but not least, we felt that retroductive approach to really tease out the theories requires really complementary expertise, but also continuous engagements within as well as between the themes and teams. And the latter was particularly important for us in this international collaborative project, where we had to communicate often at a distance. We couldn't afford really spending 8 months at a time in each other's institutions. And this approach where you go and sort of spend a week or two at a time in each other's organizations has its clear limitations, but our longitudinal nature of our study has allowed kind of enough time to kind of maintain the these deeper and continuous engagements. But of course, the challenge was to keep the momentum going, and that is something that I wanted to also emphasize. So that's all from me. Thank you very much for listening, and I just wanted to close with kind of a few links. So the first is the link to the ReVAMP project website, and it is continuously being updated as the pages are being published. But also, please feel free to reach out to me through email or other members of the Cominec as well as Leeds team. And of course, there is Twitter always there for immediate news. I'll pause at this point, and back to you, Seyé.
Thank you very much, Tolib, for the wonderful presentation. I really truly enjoyed it, and I'm sure the other members of the audience did. And I think it's this kind of presentation and work that makes me a proud member of the realist community, because it does focus and concentrate your mind on what is real in terms of how programs work. You don't have that opportunity or ability to not see as clearly as you can possibly see. So you have to sort of focus, and I really admire that in this work, but also in realist work generally. I will open the ground to questions. Now we have one question waiting, but before that question, I'll just pose one question to you, Tolib. I was thinking a lot about how you said that to pitch the theories at the right level of abstraction and for policy relevance. And it got me thinking about how might your choice of mechanisms or framing of mechanisms differ if you had a different audience. So for example, like I would assume that a core audience for this paper and for this study were Nigerian policymakers, but I just couldn't help wondering, what if they were not Nigerian policymakers? How else did you frame your findings?
Yeah, absolutely. I think the core audience was, and I've stopped kind of sharing screen so we can see each other a bit better.
Yeah.
Thank you, Seyé. I think this was an overarching consideration. I think it was really any research serves the information needs of their target audience is probably the wrong term, but it's the intended kind of beneficiaries of this knowledge. So our kind of conceptualization of that was, well, actually our expectation was that the SHUP will be sustained in some shape or form, but that didn't happen. But then the kind of the audience was largely very much state Ministry of Health as well as the Federal Ministry of Health. And clearly, if we want to particularly kind of use this as more of an advocacy issue, and indeed one of the themes emerged that eventually sort of became a distinct program theory was focusing on advocacy for the MCH to be retained on the political agenda. And there, I think the key messages were pitched more towards NGOs, the public, the kind of the common community who are pushing for that alongside the policymakers. And of course, academics, I think they're the third kind of audience that we had in mind, because we wanted to really inform policy and practice, but also we wanted to engage and advance the knowledge, both methodological as well as empirical, on the subject. So in a way, that larger scale allowed us to have fairly distinct angles to it. And this kind of a particular presentation is aimed at largely academics from the methodological point of view, but I absolutely agree that the angle from which you kind of come into the issue is very much determined by who is to be influenced at the other end. And maybe the last thing I wanted to mention is our access to both empirical and theoretical literature has also influenced the level of abstraction at which we pitched our theories. As I was explaining, kind of there was a clear dichotomy between complementary body of literature on security as well as progressively selected social science theories on trust.
Thank you very much. We've come to the end of this session, and it was a great presentation and an even greater, in my view, Q&A session, because it did engage with people a lot, and that's often rare in these kinds of presentations. So thank you very much, Tolib, for your work and for this particular presentation and the answers you provided.